like to welcome and introduce our man of the hour, Peter Lowet from Mobile Med. Peter has served as the executive director of Mobile Med since 2011. During his tenure, Mobile Med has remained committed to delivering accessible, high quality, culturally appropriate healthcare to underserved populations. Accomplishments include enhanced chronic disease management capabilities, fully integrated behavioral health services, and expansion to serve Medicaid, Medicare, as well as uninsured patients. As a community leader and respected advocate, Mr. Lowet is a member of the Montgomery Cares Advisory Board and previously served on the board of nonprofit Montgomery. Under his leadership, Mobile Med received designation in 2015 as a federally qualified health center, FQHC, and was honored this year to receive Gold Quality Leader status, awarded to the top 10% of community health centers nationally for clinical performance. Mr. Lowet has extensive experience in healthcare partnerships, strategic and operational consulting, and quality improvement. His background in collaboration and innovation is particularly relevant given our current community health challenges. He previously worked at the National Council on Aging, where he was Vice President of Strategy and Organizational Transformation. Prior to NCOA, Mr. Lowet served as the Director of Business Development at the NYU Langone Medical Center, where he managed the assessment, planning, and implementation of new strategic initiatives. He has also worked as the Corporate Director of Business and System Development at MedStar Health and as Associate Hospital Administrator for Clinical Resource Management at Georgetown University Hospital. Mr. Lowet has a BA from Yale College and a master's degree in public and private management from the Yale School of Management. And I just want to also recognize that last month, Mobile Med was again recognized by the Health Resources and Services Administration with the Gold Quality Leader designation. So Peter, thank you for being with us this morning. Afternoon.
Well, thanks so much, Dana. What? Thank you, and thank you all for joining us for this lunch. I think one of the themes of my presentation is collaboration across sectors, and so it's really nice to see familiar faces. I will, and in fact, from all sectors. So Joan, we mentioned FQHC and the designation that Mobile Med received 5 years ago. That's an incredible testament, I think, to the community. We're really proud, of course, of our track record, but it really helps to have support for community health at the federal level. And we also have friends here today who are corporate partners and vendors, nonprofit partners. And so it kind of, it's very consistent with the theme today. So I'm going to share my screen, whoops, and hopefully everyone will see a brief presentation. And let's see if I'm getting this right.
And while Peter is sharing his screen, I am serving as his eyes. So if anybody has any questions and want to put them in the chat, feel free to do so. And he is also gracious enough that if you would like to unmute yourself and ask a question, you can do so as well.
Yeah, so terrific. So I'd like to give you a little bit of an overview about Mobile Med and talk about community health during COVID and Mobile Med's response, as well as thinking about the leadership challenges that I think are going to overlap with what many of you are facing with your organizations. So Mobile Med has been around for over 50 years. Again, we became an FQHC only 5 years ago, but we were serving our mission really consistently to improve the health of low-income people in this county who face the greatest barriers to care access for 45 years before that, with very consistent values around access and quality and compassion and organizational excellence. I do appreciate Dana pointing out we're really very proud of the Health Center Quality Leader Award that we received this year from HRSA. And again, I think, we're incredibly proud of our staff and our volunteers, but really with our partners as well to make it work for people who are really underserved and under-resourced and facing really challenging social determinants of health as well. So for those of you who don't know, Mobile Med has multiple locations across the county. We're really looking to be very accessible to people in need. And so you see 6 dots across the county. These are 3 fixed sites that are it's right near North Bethesda on this map, but Rockville, Germantown, and East County, where you see Fairland on Briggs Cheney Road. And then 3 mobile sites, Aspen Hill, Long Branch, which is the dot near Silver Spring, and Gaithersburg. We serve a very diverse population, over 4,000 patients, 15 or 16,000 medical and behavioral health visits every year. It's a multicultural population. About half of our patients are Latinx. Spanish is their either first language or preferred language, but that's only half. So we also are serving lots of people whose first language is French, Amharic, some Korean, Farsi, and so forth. So it's a really diverse population, and we certainly look for. We have a very diverse staff that supports that, and we really seek cultural competency as well. So without further ado, I wanted to talk about our pandemic response around 3 themes today: accessibility, innovation, and enhanced collaboration. I guess I could put another bullet here, which is financial support, which I would be remiss. We have been very fortunate at both the government levels as well as with philanthropy to have response. This has been a real challenge. It's been real uncertainty, and it's been expensive actually to engage in this. We have been fortunate at the federal level to receive early CARES Act funding that was open to community health centers. So it was really important for Montgomery County to have designated FQHCs, because that was the criterion for getting that CARES Act funding. And so even though, whether there's need or not, I mean, there has been need in the county that was somewhat hidden by the average affluence and average good health of this county. I think we all understand, and I think the pandemic and some of the other social justice issues and challenges during 2020 have made the whole world focus on things that we certainly are well aware of, which is around not just averages, but the incredible disparities in care and in access to care and in the social determinants of health. And so it really behooved us to demonstrate the huge need, again, not just on average, but the fact that this county has a very large population that is not well served by without community health organizations like Mobile Med. So with respect to our crisis response, first, we had a temporary consolidation. I showed on the map 6 locations. We very quickly decided to consolidate our van sites into our fixed sites. We did that for a couple of logistical reasons and safety reasons. So our sites were at a couple of churches and a community center. Well, the diocese of the Episcopal Diocese closed programming last spring because of COVID. Our van at the Long Branch Community Center, well, Long Branch was closed and then repurposed to be an overflow shelter or overflow facility for homeless services. And so there was those logistical challenges, but there was also safety. We felt like we couldn't do infection control adequately on the van, it's cramped. People are never social distanced and often sort of crossing paths. So we decided to do that. We obviously also put in lots of safety protocols, many of the same ones that you would do in your organizations, but also heightened with respect to being a primary care provider. And so with respect to PPE, so we really required all of our staff to wear full PPE in the clinic all the time. That includes face shield or goggles, as well as mask and gloves. Gown we started with, and we actually decided a couple of months later to stop requiring gowns other than during physical exams where clothing could get soiled. And we also were doing things with patients. We were taking temperatures and health screening at the door. We were making sure that patients were masked. We separated lots we social distance as best we could. We isolated, we got people into exam rooms as quickly as we could and so forth. So again, some of the same protocols that I suspect you all are doing with your groups, plus. We also really focused on the patient during this time. And so these were a couple of things. We were getting more calls, again, back in the spring than really than ever before about just people panic, not just our patients, but very often people who were simply Googling and just trying to get any info about COVID, about testing, panic about treatment and so forth. And so we really wanted to make sure that we had a good process for telephone triage that also involved getting some of our volunteer doctors involved in the triage process to expand beyond the capacity of our staff. So we had physicians working with patients to really understand their symptoms and what should happen. As most of you know by now, all of you know by now, with COVID, much of the treatment for people with mild symptoms relates to self-quarantine. There's nothing really that benefits people to go to a primary care setting or an ER or anywhere else if they have mild symptoms that can't be treated and managed at home in terms of fever reduction, over-the-counter fever reduction items, and drinking fluids and sleep and trying to move around some and so forth. So lots of that discussion was done with triage, and of course people were desperate to get COVID tests, and so we were for the most part referring to, again, back to the collaboration, county testing centers and others. We quickly pivoted to telehealth, like many practices, and I don't know if you all have been to your primary care provider in the last 6 or 8 months, but we had not done telehealth before. And by the end of March, we were doing entirely telehealth for behavioral health, and most all telehealth for our medical visits as well. So we really quickly pivoted. We never closed for in-person medical visits, but I'll show you in a couple of minutes what happened to our volume. But again, telehealth was a really critical lifeline. And what we also did, I think people may be aware, and this is not just for disadvantaged people. The folks we serve, 80% of the people we serve are uninsured, and the remainder are mostly Medicaid with some low-income Medicare. So even after the ACA, this county has a very large number of residents who are not eligible for Medicaid and not eligible for subsidies on the exchange, the so-called Obamacare plans. And that's, frankly, it's mostly the nature of that we have a high immigrant population who may very well not be eligible for those programs. But you also may know that that everyone, including insured people, including people who've kept their jobs, including people who are well off, everyone is it has been reluctant to engage the healthcare system if they don't have COVID. And so you've heard about hospitals being down 30% for their non-COVID activity, even after they reopen for elective procedures. Private practices are down, I believe, 31%, according to a CDC survey. And we were facing the same thing, a huge drop in volume during a pandemic, ironically. So we therefore had to do a lot more proactive case management. We wanted to reach out first to our most vulnerable patients. So those people who are homeless, seniors, people with diabetes, particularly under poor control, those types of subpopulations, we needed to reach out to them. We needed to tell them that even in a pandemic, they need to take care of themselves. And frankly, even again, 8 months later, we're looking to expand our expanded proactive outreach and case management, not just to our high-risk people, but to others who haven't been seen because people have delayed their preventive care and their other services. So it's a huge ongoing issue that I think caught some people flat-footed. We started from the get-go to try to engage at least the high-risk folks. We did some innovation. We did much more curbside activities. The first few months, we quickly actually started to do deliveries of essential medications. Insulin was the most obvious when people had even more economic distress with our patients. Medications are often what they cut corners on if it means trying to put pay the rent or put food on the table. We were really concerned about our patients receiving those, and so we were acquiring insulin, and for those people who couldn't make it to the clinic, we also started deliveries, and we built in with the deliveries also some curbside testing. You can see in these pictures that we started testing for a couple of really important things. One was for our anticoagulation patients who need some monitoring. These are people, again, chronic situations or post-hospitalization, really important to monitor that they're not having challenges with their meds, and also doing A1Cs, curbside point of care A1C tests, if you will, for diabetes care. And so what we could do at home, or what we could do at the curbside for people who didn't want to go into the clinic, was an expansion. And the last piece, we wanted to get more devices to people, whether that's thermometers or blood pressure cuffs, especially for those with high blood pressure, hypertension. Many of you, if you do have chronic conditions, probably have those devices at home. Some of our patients, again, being low income and really challenged around resources, may not have had them before, may not be able to find them during COVID or afford them. And with telehealth, it was so much more effective to be able to have some patient monitoring. It was, with us, without our being able to do intake, including vital sign checks, it was very important to make sure that patients could, for example, give a blood pressure reading to make it a more useful visit, and for us to be tracking their condition. And around collaboration, it really has been a community effort around COVID and around all of, again, the social determinants that really do drive health. So we've had a patient navigator around COVID. When we refer for testing, we follow up on the tests, whether positive or negative. We're following up with patients. We continue to reach out to them to make sure that their condition hasn't changed and that they're following a treatment plan. We are participating in in some of the testing events going around the county. We are also really interested. There's unfortunately not a lot of extra flu shot serum lying around. I hope you all have gotten your flu shots, but that's another pathway. One, it's really important to reach the underserved populations for flu shots. You all can go to your doctor or to CVS and get a free flu shot. For people who are uninsured and have limited resources, there are fewer free locations for flu shots unless they are a mobile med patient or another community health patient at another community health center. So these events, they're going to be limited because of, in this case, the county just has a limited amount, a limited supply. Boy, they had to order it back in January. I don't know if you all remember January of 2020, but it was something of a different universe as people were imagining public health challenges of October 2020. But we think it's a really important type of event for us to be involved with, both for cultural competency, but also, frankly, to get people engaged about all of the other elements for their health, including, obviously, insurance and primary care. And so, likewise, we're beginning to collaborate and do outreach through the hubs that have been developed that are really focused on food distribution, but are really want to be attentive to some of the other real stressors in their clients' lives. And so we have a clear and transparent ulterior motive for participation in these events. One, we want to help. These events on their own are really helpful. Obviously, again, food is a critical determinant of health, but we also want to get people and get 160,000 people in the county are newly unemployed. Many of those people have lost their employer-based health coverage. We want to make sure that people are aware of their enrollment options for people who are eligible. There are many people who are newly eligible for Medicaid and sometimes for Obamacare plans if their family income has dropped significantly. We also want to make sure that people know who may not be eligible for these plans that, and also about other public benefits. But we also want uninsured people who can't enroll in insurance coverage, that Mobile Med is there for them. And then we want to just make a public health message for folks, which is primary care is important. So if you have
Peter,
a regular primary care doc, sure.
Peter, before you move on, you've gotten a couple of questions in the chat that are relevant to what you're talking about. The first one is asking how Mobile Med fits in and or works with other medical safety net provider, other community health organizations in the county.
Sure. So we are a participant in the Montgomery Cares program, which I suspect that the person asking the question is aware of. That's a really valuable program, county-funded program for low-income uninsured residents. And so we engage with them. And in COVID, that's been involved with a really centralized approach to some difficult challenges. PPE is perhaps the most obvious, where acquisition jointly around supplies was a real advantage. Now, I will also say it was a real advantage that the county wanted to support and reprogram funds for a significant amount of supplies as well. But that's one example that we were really stronger together than separately. Beyond community health centers or safety net clinics like Mobile Med, we have always collaborated with the broader healthcare system. We have lots of volunteers, including some doctors in private practice, and we have incredible hospital partnerships. So we work with Adventist Healthcare, which is Shady Grove Medical Center and White Oak, as well as Suburban Hospital in Bethesda. Those are incredible partners for us. And in COVID, we were engaging with them about transition plans and emergency pieces. We actually almost Lent, we actually offered, Suburban Hospital asked us for a van to do some parking lot COVID testing for some of their elective patients. They ended up not needing it, but I think we wanted to focus very much on the whole transition piece to and from the hospital system as well during the pandemic. Is there another question, Dana?
There was another question that was asking you to talk a little bit more about physicals in regard to CDL holders and what that is like in response to the COVID crisis.
In terms of having access?
Yes. Did we lose Peter?
I can't hear him. No, yep, lost him.
He looks frozen.
Well, he's a black screen for me. Well, that's fun.
Dana, I think my question froze him.
I think so too, Tina.
Oh my God.
Let me see.
Michelle, are you able to reach out to Peter? Oh, there he is.
There he is.
Hi, Peter. Well, you made this interesting, didn't you?
Did I do something?
You froze for all of us, but I'm sure it was not your fault. We will blame it on Zoom and just keep on going. So we didn't hear, we were asking you about access for CDL holders to receiving a physical, and that's where we lost you.
Yeah, and I'm sorry about that. So,
That's right.
so we are, so we are now doing physical. I don't know when you lost me, but we are doing physicals now. We did, again, delay some things in the spring because of just caution. But people can come in for physicals and for preventive screenings. Again, to our fixed sites, to our 3 fixed sites. We actually expanded hours at those sites. So 2 of those 3 were part-time. They're now open every day of the week because we, again, consolidated from those van sites. So one can just call for an appointment.
Yeah. So can I clarify something? The question, I believe, was about CDL. So that, is that drivers?
So that was specifically a CDL physical for, yeah, I mean, we do, yeah, we do those kind of physicals and other, when forms need to be completed. We don't do workers' comp, but we certainly do physicals like for CDL.
Wow, that's great to know.
Thanks, Peter. That's
okay.
We do have some other questions, but I'll let you continue on with your presentation.
Well, I'll try to wrap up soon. So you can see normally, so our volume dropped by, well, by 40% in April. It actually dropped starting the second half of March as people just, both because of lockdown or quasi-lockdown orders, but also just the incredible fear and anxiety in the community. What I mentioned to you is that by the end of March, telehealth was completely up and running for us. And in fact, all of behavioral health, those 154 visits in April, we were very pleased that they maintained their capacity and could see that's really that was actually ahead of our typical volume, monthly volume for behavioral health. Our medical visits dropped precipitously, and you can see that telehealth from April forward started dominating our medical visits. And so part of that was, again, our telling people if it wasn't appropriate for them to come into the clinic, for them to not come into the clinic. So for example, if the only reason for their visit was around COVID symptoms, that was not a good reason to come to into the clinic and put people at risk. And so you can see that a couple of things. One, our volume is bouncing back, which is really good. And second, our in-person, the orange bar is, the blue bar is bouncing back, which is also good. We decided that toward the end of the summer that we needed to make a concerted effort to do things like make sure that women who were due a cervical cancer screen knew that we were, open for business for that. We wanted to refer people for mammograms. We wanted to have a periodic in-person visit for their chronic disease. So we could do, for example, very well chronic disease management via telehealth for the short term. You can manage a diabetes exam for a few months via telehealth, especially if you get, say, the A1C test, and you can get some other vitals. A provider can do something via telehealth. What can't you do? Well, you certainly can't do a foot exam, which requires touch by telehealth. It's just real, providers want a physical, want to be able to engage physically with someone periodically. And so, again, we're really happy that in-person is growing. Again, our volume is still down. It's just hard to believe. Our visit volume is down. Our activity is up. Our visit volume is down. And so we're really pushing to reverse that trend. So I'll just mention a couple of other challenges that hopefully this overlaps with what you all have been thinking about in your own roles. First, in the spring, we were all trying to get to the summer. I mean, we really had an outlook, and this was, we communicated extensively with staff and all, but it was all about, we can all do this, right? We can sort of get through this. And it was very much of a sprint mentality. And it's been a real challenge to actually, not only has it gone on for 8 months, but the twindemic is very real. And there's great uncertainty about 2021. We can be optimistic about the vaccine and about therapeutics and other things, but this is not simply going away, and it's not going away on November 3rd either. As we all know. So we did. One of the pieces was certainly looking to put patients first at all times. Staff wellness. I mean, employee wellness has been a huge issue again across society. At Mobile Med, it's incredibly stressful. People have to wear PPE all day long, which is both a physical stress, but also a mental stress. People are not able to engage collegially like they're accustomed to. We're a small, tight-knit organization, and it's hard to not have lunch all together and not do the small things. Staff won't, so it's been an issue. We've tried to be proactive about it. We created an ad hoc committee around staff wellness, made up of staff, not a management driven effort. One of the most important initiatives, they've sort of thought of some sort of immediate needs as well as thinking about longer term wellness around Mobile Med, is that we've never had an EAP program before. And this committee encouraged us, if not now, when? And so we're looking to institute an EAP again for the first time at Mobile Med. But we really need to be very intentional about wellness. We can't simply talk a big game. We are doing some mindfulness training every week. We're asking people to take a little bit of time for themselves. We're trying to design jobs that do have to happen in the clinic, such that we're having as many people as we can take at least one day at home to do case management and some other things that can be done by telework at home, just so they can unplug a little bit from the stress. And the stress is even higher, when there are positive cases. I mean, this week, they learned, the clinic staff of one of our sites learned of a patient who came in positive, unknown, that they didn't know was positive until after the visit. These things are going to happen increasingly. That is really stressful, even wearing PPE. Even that patient and the staff are all wearing masks face to face with each other, but we all understand that that's a risk mitigator. It's not a risk eliminator. There have been consequences about fatigue. So I mentioned the PPE and our guidelines and our protocols that we are really very serious about. It really is, I worry about the safety of our staff every day, as well as the health and safety of our patients. But there's been real fatigue, and we've had some ramifications from people who've dropped their guard. So we had a staff member who tested positive, and we determined that, to be conservative, we thought that there were some cross exposure, which is exactly what all of our protocols were designed to avoid. We wanted to be conservative because we really thought that, because of COVID fatigue, that there had probably been some laziness in terms of interaction at lunchtime with people, not a gross negligence approach, but enough just sort of laziness or fatigue about it. So we had to make a huge choice to shut down in-person care, but that whole staff, that subset of staff needed to work from home for 2 weeks. And that entailed also closing the clinic for several days to in-person, one of our locations, for in-person care. So there are huge consequences. And so we hope that this was actually a small lesson in that last case. And we've been incredibly proud of the safety of staff and patients, but every day, we have to sort of prove ourselves again.
Peter, this is there's another question, and I feel like this is a good time to ask it to you. You talked a little earlier about involving your staff around wellness, but I'd love to hear, the question reads, as a leader of an organization that must react and respond quickly to change, how do you make time and engage your team in the proactive considerations required to be a forward-moving organization working on the business rather than in it?
That's a tough question, and I'd love to hear the answer from the person asking the question. But I think again, this is really hard. One of the things is what I mentioned about unplugging. I think it has been very valuable for people to work from home occasionally, even if they have an in-person type of job. I think that lends perspective, and it gives people a deep, just a chance to exhale. And I think that perspective is really hard. But it's we are lucky that we have behavioral health in-house. And so we have people who are trained in mindfulness in-house to be able to lead some efforts around that. And we hope that offers people a chance to relax and also, again, get perspective. But it is hard. And I didn't even mention, our staff is diverse, and it's socioeconomically diverse as well. And so, our staff are going, because of the support, both the public funding support as well as philanthropic support, we were able to not have any layoffs or furloughs during this entire stretch. We're really very proud of that. We certainly tried to convey and communicate that, but we didn't want to overplay that hand either. Again, back to this, not knowing what the future holds. It's not like we could say on March 15th that hey, we're guaranteeing that everything is going to be hunky-dory for folks, right? We could not make that kind of guarantee, but we could communicate what we were doing. We could communicate that that we were protecting jobs, for example, and doing that. But I think perspective, I mean, I think it's a great question, but I think perspective is really hard right now. And I think it's even harder because of the lack of collegiality. A lot of the perspective that this is not just, you're not just buried by the job, comes from collegiality and engagement and just fun and being able to go up to someone else's desk or whatever and chat. And now, if I see someone coming over, we're saying, stay socially distance and be wearing masks if you're going to come over. And I mean, it's just not, you're not really encouraging the kind of informal, there's no water cooler talk going on right now. So there's I mentioned productivity, which is a concern of mine around for long term. But I think that so much productivity comes from happy people. And we're worried about that. I think that management needs to walk the walk and show that we are being responsive to the concerns of staff. And I think we're doing that to some degree, but I think there's a lot of room for, for continuing on that.
So Peter, I have two questions if I could.
Sure.
So one is, you mentioned that you're a primary care facility, you do primary care. Can you share a story how the services at your clinic have impacted someone with a chronic condition like heart disease or diabetes? And full disclosure, Cesar Palacios from Proyecto Salud is one of my dear friends. He was a classmate of mine. And then my second question is, how can those of us on this call help you? So I know we're all connected to different organizations, and right now I'm very entrenched in helping a local food pantry. So I have some ideas for you. So two different questions or thoughts for you to answer.
Awesome. So first, I'll take your second one first, because I just want, the first and foremost, again, I want, everyone should be an ambassador to the fact that this county is blessed to have community health resources, including mobile med and including, Proyecto Salud that you mentioned with Cesar. And so that there should be no barrier that can't be overcome for people, certainly no financial or cultural barriers that should stop people from getting care. So much of it is, but we unfortunately, awareness is not as high as we would like, particularly for people who don't think that this was supposed to relate to them. And there's the stress and issues about the pandemic, but there's also stigma issues and other issues, all of which sort of get people, between stress and stigma, people's brains shut off, right? And really don't think about what's good for them and their families. And so they really need, they need friends and family and neighbors and others to let people know that there are resources out there and, help people make a phone call with the person. I mean, people's capacity to help themselves drops considerably, right? All parents understand this, right? When your kids get stressed, their IQs go down, right? Even though all of our kids are smarter than us, they're not smarter than us when they're upset because they can't think straight. I mean, they literally cannot think straight. And we have, our entire society is not thinking straight right now. And so we really need to help each other when we understand resources and the like. So this is first and foremost. It's really easy to access mobile med. You can also have people access Mobile Med if they have questions about insurance, and for some reason they don't want to, reach out to a government person about Medicaid or something like that. Talk to Mobile Med about those sorts of questions. So I will do my plug. We certainly want people to be thinking about these elements. Michelle is on the call, as well as me, and please reach out to either of us if you have any ideas about this. I will come back to your first question, which is, the patients, and I wish that I had a patient with me today. As an FQHC, actually, a majority of our board have to be active patients of the health center. That's a requirement because the federal statutes really want to make sure that Mobile Med and other FQHCs represent and think about community and aren't just a more traditional nonprofit that sort of thinks about mission, but not necessarily coming from the community perspective directly. And so, people have joined our board to give back because of the situations of chronic disease management. So most people come to Mobile Med late. This is not going to surprise people. People who are lower income, have heard their whole, healthcare is expensive. They don't know that Mobile Med doesn't turn anyone away, due to an inability to pay. So they don't even know to ask the question. And so they often come to us late when their conditions are not under good control. So we have a disproportionate number of people with diabetes or hypertension or other chronic diseases, and also disproportionate number of people with depression or anxiety. And so we have countless examples of people coming in who have undiagnosed disease like hypertension, and we're able to engage with them, be, again, culturally competent around these things, get them free medications if they are low income and uninsured, engage with them about their medications and about any challenges that they may have to try to improve compliance, and have them also connect to behavioral health, because so much chronic disease mismanagement comes from the comorbidities of behavioral health. And so people, and this is true for all income strata, so please, you should think about it for everyone people with, say, depression. One, depression is a chronic disease, but second, they're not going to manage their physical or somatic disease well in a compliant way if they're not managing their depression. And so we have so many examples that people are not eating right or sleeping right or managing or taking their medications regularly for diabetes because they have depression. And so for us to be able to treat the whole person is really helps, and really it just changes lives. We were founded over 50 years ago by a couple of physicians who were actually tutoring in an African American neighborhood, because this was the time of desegregation in Montgomery County. It's hard to believe that was only 52 years ago that Montgomery County's schools were getting desegregated, and I feel like we continue to have a social justice conversation, or haven't had enough social justice conversation over the subsequent 52 years. But what they realized was that the parents of the kids whom they were tutoring, these physicians, it was the parents who were not taking care of themselves, and that there was really unmet need. And again, parents really weren't even thinking that was part of their responsibility to take care of their family, was to take care of themselves. So, but great questions.
Peter.
And I know Teresa from being involved with one of your former employers.
Yeah.
So thank you.
You're welcome.
Peter, it's hard to believe, but we are actually about at the end of the hour. I want to thank you for all of the fantastic information that you've shared. We probably could have done this for another hour or two. I want to thank everybody who's participating with us this afternoon. What I would like for you to do, just to close us out, you've definitely talked about, and we appreciate the honesty in which you've shared with us the real challenges that I think many of us are facing also within our own workplaces. But what I would love for you to do is to just share with us what's getting you through as a leader. What's keeping you hopeful for getting through this difficult time?
Well, two things. One, I am really happy that my family is in good shape, and so we're feeling really fortunate and with glass half full. I think that's a huge part of any leader's perspective is outside of the workplace. I am incredibly proud of my staff and what they're doing on behalf, and I think we're making a huge impact in this region, and that sort of keeps me going. And I will tell you, we really do live in a community or a set of communities that have figured out that we can make it work together. So the whole "it takes a village" cliche is so obvious. So I really, one of the things that keeps me going day to day is that Montgomery County and the multiple sectors, the kind of folks on this call and others, are trying to pull in the same direction. There's uncertainty, there's lack of information, and there's lots of barriers, but I think being confident that we can actually collaborate. I mean, every call we make to engage with people to see whether we can work together, again, not with funds changing hands, but just work together, has been a really positive, a conversation of positive energy. And that has been really helpful for me personally.
Thank you. So we are at time, everyone. Thank you for joining us for another Conversations with a CEO with Leadership Montgomery. We'll send you some follow-up information and ways to keep in touch with Peter and Mobile Med. And we hope to see you again soon. Thanks, everybody.
Thank you so
Thanks so
much.
much, everybody.